Friends, am I audible?
Yes, yes.
Okay. So thank you, Dr. Namrata, for having me here for this program in the morning. Phaco emulsification in most of the post-vitrectomy cataracts are basically routine from the surgeon's perspective as well as from the audience when he watches the video. Particularly situations where vitrectomy has been performed for, let's say, periretinal membrane or macular hole surgery, a simple vitrectomy. The challenges show up when we operate upon eyes that have undergone multiple sittings of vitrectomy or very advanced vitrectomy with silicone oil in situ. So I have a series of videos to bring out all these points, but I'm just going to show you one video which may not cover the entire gamut of challenges that one could face while dealing with these cases, but at least some will be shown. Now, this is a patient with the emulsified silicone oil bubble in the anterior chamber. These globes are generally very soft. Sometimes it may be very difficult to make the incision. So it is a good idea to inflate the anterior chamber with BSS to firm up the eye. Before proceeding to the next step of capsulorhexis, it is important to exchange the emulsified silicone oil bubble with BSS, as has been done here. I believe in trypan blue staining in these cases in a routine in all situations, because the capsulorhexis may be complex in situations where there has been silicone oil in the anterior chamber for a long time. There will be capsular fibrosis. There may be capsular plaques. Some of these patients may have hazy cornea, so you need to have a consciousness of the rhexis, which is better with the trypan blue dye stained anterior capsule. And then when, if there is a deep anterior chamber overlocking, then again, into knowing where the rhexis is makes it much easier. So rhexis, as I said earlier, has to be done very carefully. Sometimes it may be a litmus test for the zonular stability. In certain cases of post-vitrectomy cataracts, when they come to us with extreme degrees of nuclear sclerosis, the lenses may be loose. So in that case, we have an idea about how loose the zonules are, and we may have to use a rhexis forceps to complete the capsulorhexis. Capsulorhexis is standard size, maybe 4.5 to 5 millimeters in size. Cortical cleaving hydrodissection has to be done if you are sure about the integrity of the posterior capsule. I would not do it in patients where the patients have come with a very acute and rapid opalescence of the lens immediately after vitrectomy, or a white cataract, post-vitrectomy white cataract where the patient has been operated elsewhere. So I would use a non-hydrodissection based, non-rotational technique of nucleus management. Lens iris diaphragm retropulsion syndrome or reverse pupillary block is common in many of these cases, but particularly patients with high myopia. So use the maneuver which I've just shown, where you use the Sinskey hook, or even sometimes the Phaco tip, to raise the iris from the anterior lens capsule so that there is rapid equalization of the pressure gradient between the anterior chamber and the posterior chamber. As regards the nucleus management, use an appropriate technique. Now, if it is a choppable cataract, not extremely hard, I'd be using a direct chop technique, using a chopping technique after a little bit of grooving or making a crater at the center, as you see here. On the other hand, if it is an extremely hard cataract, I may go for a modified stop and chop technique. So use a technique that is safest in your hands and most friendly to the capsulozonular apparatus. It goes without saying that you need to use copious amount of a dispersive OVD. These eyes have been operated once already or maybe multiple times. They might have harbored silicone oil in the anterior chamber, so the corneal endothelium may not be very healthy. So it is a good idea to ensure that the cornea stays protected with a dispersive OVD all the time. So once the nucleus is removed, it is important to remove the capsule as aggressively as possible, the cortex as aggressively as possible, because these eyes are more prone for an aggressive posterior capsular opacification, capsular rhexis rim fibrosis, eye intraocular lens decentration, and they may also have a higher incidence of posterior capsular plaques. Sometimes it may be possible to peel off the plaque from the posterior capsule. In certain cases, they're integrated with the posterior capsule, and if it is right at the center where the visual axis passes through, so it may be necessary for us to do a posterior capsulorhexis and have a posterior optic capture We don't want the silicone oil to come anteriorly in the postoperative period. And as you see here, I do a very extensive anterior capsular polishing here. Never use a silicone-based intraocular lens. So ideally a hydrophobic acrylic lens or at all a PMMA lens or a hydrophilic acrylic or a PMMA lens. Since these eyes are pretty soft at the end of the surgery, so it is important to close the incision with a tenon nylon suture. There have been situations where I have used tenon nylon even to close the paracentesis incision. I'll show another case before I wind up. Now, this is a patient where again, there is silicone oil filled in the posterior segment. The pupil is small sized and there is emulsified silicone oil bubble in the anterior chamber. So what I wanted to emphasize here that there is always a posterior upthrust because of the presence of the silicone oil in these situations. Silicone oil has to be there. The retina surgeon had mandated that silicone oil should not be removed. So towards the end of the surgery, nucleus removal, when occlusion has to break for you to remove the last chunk of nucleus, there has to be some amount of post-occlusion surge. And if you're not careful, you can end up with a situation like this, silicone oil presenting into the anterior chamber. So most of the time, if you inflate the anterior chamber, pressurize the anterior chamber, the emulsified silicone oil bubble goes back into the posterior segment and things are going fine. So here, as you see here, I've used a 3-piece hydrophobic acrylic lens and everything seems to be well at the end of the surgery. So friends, in Phaco in vitrectomized eyes, remember it is a challenging situation and it should be performed only by an experienced surgeon. Surgical issues play a very important role in the eventual post-op outcome. And there are other factors that determine the ultimate visual acuity that the patient regains. So use of proper surgical approach and a proper patient counseling may be mandatory because anatomically everything may be fine, but the patient may be disappointed if the patient has not been primed preoperatively about the relatively poorer visual outcome in these patients. Thank you very much for your kind attention.
Thank you, Arup, so very much. What I liked was the last thing you said,